Welcome to the Anesthesia Learners Academy. If you're a PGRN intern stepping into the ICU, you already know it's a completely different beast compared to the regular hospital floors. I mean, it's probably the reason you haven't slept much this week, right? It's fast-paced, highly technical, and the stakes are absolutely sky-high. But hey, don't worry. Today, we're diving into a definitive survival guide. We're going to break down the core fundamentals you need so you can not just survive, but truly thrive in there. We completely get that day one can feel incredibly overwhelming. In fact, one of our sources uses a perfect analogy for this feeling. They say stepping into the intensive care unit is just like being in the Army or the Commandos. You are literally stepping onto the front lines of patient care. It's a demanding, high-pressure environment where you rarely have the luxury of time to sit down and take a prolonged history. But today, we're going to transform all that chaos into a highly structured, manageable framework for you. So here is our roadmap for this explainer. We'll be covering Welcome to the ICU, Deciphering ICU equipment, mastering bedside rounds, writing the ICU note, and finally, lessons from the ICU. Let's jump right into Section 1, Welcome to the ICU, Mindset and Triage. Now, the absolute fundamental difference between the general floor and the ICU is the need for intensive, continuous monitoring. On the wards, patients generally have stable physiology that just requires basic routine checks. But ICU patients, it's a whole different ballgame. Their physiological parameters are deranged. They require unique hemodynamics management, continuous medication titrations like vasopressors, and advanced life support from super complex equipment like mechanical ventilators. You aren't just checking in on them, you are intensely managing their moment-to-moment survival. And because your resources and time are finite, you've got to mentally triage your patients into 3 distinct categories. Category 1 patients are mostly just there for observation, like a stable post-op patient who might deteriorate but is currently doing fine. On the other extreme, Category 3 patients are extremely sick, on multiple supports, but unfortunately have a very poor prognosis. It's Category 2 where you need to direct your absolute highest focus. These are the critical but salvageable patients, maybe someone in reversible shock or someone requiring a ventilator. Pouring your energy into Category 2 is where your timely, aggressive interventions can truly change a patient's destiny. That's where you really earn your stripes. Which perfectly transitions us to Section 2, Deciphering ICU equipment, machines as teammates. Look, if there is one thing you need to make your best friend immediately, it's the arterial blood gas, or ABG. Consider this the absolute bread and butter investigation tool of the intensive care unit. Standard lab draws, they can take an agonizing hour to come back. But an ABG gives you vital, real-time data in just minutes on a patient's oxygenation, carbon dioxide clearance, pH balance, and electrolytes. It gives you immediate, undeniable clues about how critical your patient's status actually is, so you can make rapid adjustments to vents or meds. And speaking of the airway, the A in your ABCs, when escalating oxygen support, you always want to start with the least invasive method that actually works. Think of it like a ladder. You start with simple nasal prongs, which max out around 6 liters, then move up to a face mask. If they're still struggling or retaining CO2, you escalate to BiPAP or non-invasive ventilation to force some air in and support their breathing effort. Finally, if they simply cannot maintain their airway or oxygenation, you go all the way up to invasive mechanical ventilation with an endotracheal tube. Having this ladder in your head absolutely prevents panic when a patient's sats start dropping. For managing the C, circulation, you're often going to need to go way beyond a standard peripheral IV. When your patients need fine-tuned infusion pumps for vasopressors or highly osmotic agents, you'll be relying on 3 primary central line sites. The subclavian vein gives the patient great mobility and has a low infection risk, but it's non-compressible if you accidentally cause a bleed. The internal jugular vein, or IJV, is the real workhorse of the ICU. It's compressible and super common. Then there's the femoral vein. It's your go-to in massive emergencies or for patients with severe coagulopathy since you can easily hold pressure there. But be warned, it carries a very high infection risk. Moving right along to Section 3, Mastering Bedside Rounds. Look before you touch. I know it is incredibly tempting to walk right up to a patient and immediately start using your stethoscope. But in the ICU, before you even lay a finger on the patient, you have to follow a specific workflow to gather a wealth of data from their surroundings. Step 1, look at the monitor to gauge their heart rhythm and blood pressure. Step 2, check the infusion pumps to see exactly what meds are supporting them right now and read those ventilator settings. Step 3, examine their lines for any signs of infection and check the urometer for their hourly urine output. Only after you've absorbed all that context do you actually move to Step 4, which is physically touching and examining the patient. But here is a absolutely massive pro tip. Trust your clinical eyes over the machine's numbers, especially for respiratory distress. A monitor might be happily beeping away, showing a totally normal respiratory rate of 18, but if you look at the patient and see them sweating, flaring their nostrils, or using accessory muscles, they are in trouble. The machines are your teammates, sure, but you are the doctor. Treat the patient, not the monitor. All right, let's get into section 4, writing the ICU note, the systems-based assessment. ICU patients are complex, right? It's like a giant puzzle. If you just try to mentally list their problems, you are inevitably going to forget something vital. You absolutely must evaluate every patient system by system, using this framework so nothing slips through the cracks. Start at the head with neuro, checking sedation and pain levels. Then cardio, looking at pressors. Pulmonary covers their vent settings. GI handles tube feeds. Renal is absolutely crucial. You got to verify they're making at least 0.5 ml per kg per hour of urine to clear out those toxic metabolites. And finally, heme/ID covers antibiotics and skin checks to prevent bed sores. Seriously, it's a foolproof safety net. On top of that, add this checklist, known as the bundle, to the very end of every single presentation and note you write. Think of it as your holy grail for the daily table stakes of intensive care. Does the whole team know the patient's code status? Are they on the right sedation? Are we protecting them from stress ulcers and blood clots with GI and DVT prophylaxis? How are we feeding them? And what's the ultimate disposition plan for the day? Checking these 5 simple boxes daily doesn't just save you time, it literally saves lives. You also need to know the difference between an admission note and a follow-up note, so your communication stays clear and targeted. Your admission note is the big picture view. It focuses on the primary working diagnosis, exactly why they couldn't stay on the normal ward, and establishing their baseline vitals. Your daily follow-up notes, though, those are much more tactical. They zero in on what happened over the last 24 hours, their current status using that systems-based breakdown, and the very specific plan for the next 24 hours. And that brings us to our final part, Section 5, Lessons from the ICU, the human element. Working in this intense environment is inevitably going to change you. It teaches you that time is your absolute most precious resource. You just cannot procrastinate when a life is on the line. It teaches you that making a human connection, holding a hand, and treating a patient as a real story rather than just a case is just as vital as adjusting a vent setting. You'll learn to focus on providing your absolute best effort because despite doing everything perfectly right, you can't control every clinical outcome. You'll also see that your impact multiplies exponentially when you take the time to teach your nurses and junior residents. And lastly, you'll realize that true, meaningful purpose is found by stepping right outside your comfort zone. While we hope this crash course gave you the practical confidence you need today, if it did, please hit that like button, subscribe, and share this Anesthesia Learners Academy explainer with your fellow PGs and interns. The more we learn together, the better care we can provide. I'm going to leave you with one final thought to reflect on as you take a deep breath and walk into your very first shift. It's not just about knowing the protocols. It's about the presence you bring to the bedside. When the chaos starts and those alarms start ringing all around you, what kind of doctor are you going to be for your patients? Go out there and do some great work.